uh, please feel free to put your email address into the chat box for me, and we will make sure that CME goes out to you if we are able to offer CME for this session. So that being said, I am going to turn things over to Dr. Collins, and if you give me just a moment, I'm going to go ahead and share my screen, and all of you should be able to see a PowerPoint. Can I get a thumbs up if you can see that PowerPoint? Yep, good, perfect.
We can see it.
We can see it, beautiful. Good. Thanks so much. All right, Dr. Collins, I'm going to turn it over to you.
Thank you. So first of all, thank you all for attending. I don't know if any of you have seen a case of this yet, but I was in the hospital a couple of weeks ago, and we had our first case at CDPH. And I'm certainly not going to call myself any kind of expert. I'm not, but at least I've seen a case. And I thought I would share with you guys what we saw and what I think is becoming a pattern with this problem. So thanks again for everybody that's attending. And hopefully you'll get some idea of what to look for out of this. That's the whole idea. Okay, so to start off here, this is the actual case we saw here at CDPH. A 34-year-old male. He had relatively limited past medical history. He came to CDPH Emergency Department on September 3rd complaining of shaking chills, nausea, myalgia, anorexia, loose watery diarrhea, increasing shortness of breath, and pleuritic chest pain. The symptoms began approximately 10 days before he presented to our ER. On August 29th, he began to develop wheezing and cough with a slight production of yellow phlegm. Things just got worse, all these symptoms prompting him to present to this emergency department on September 3rd. As far as his past history, he has a remote history of depression and a remote history of attempted suicide by overdose, a remote history of alcohol and substance abuse. He's had wisdom teeth extraction. He quit smoking cigarettes entirely in his mid-20s. Remember, he's 34 now. He works as a custodian at a local movie theater. He vapes a THC product 2 to 3 times per week, and he rarely ever smokes marijuana anymore. He's been off alcohol for years, and he quit smoking in his 20s. So initially, his first symptoms were malaise, fever, chills, nausea, vomiting, and diarrhea. And then 72 hours later, he developed respiratory symptoms of cough and chest pain and dyspnea and increasing weakness. But just notice that that's not what he started out with. That's going to become important. So in the ED, he looked acutely ill. He was weak. He was dyspneic. His temperature was 101.8, blood pressure 152/94, pulse 113, respiratory rate 30, sat 93% on 6 liters. Bilateral inspiratory crackles on exam, no rashes, normal, abdomen non-tender. Yeah, so white count when he presented to the ER, 15,000. Hemoglobin a little low at 10.8, platelets up at 623, INR essentially normal. LFTs elevated somewhat, AST of 58 and ALT of 79, bilirubin 2.3, procalcitonin 0.9, lactic acid 1.8, UA okay, hepatitis panel was all negative, HIV testing was negative. So as far as his micro went, he had 2 sets of blood cultures on admission that were no growth. He was tested for tick-borne illnesses, which you might think it would be reasonable because of his, a lot of the tick-borne illnesses are non-specific. So we did all that, and they were negative. There's something Pontiac fever, even without pneumonia, that you can get with Legionella, but his Legionella antigen was negative. His strep pneumo antigen was negative. He did produce a sputum which grew a light growth of MRSA. We tried to get a respiratory panel sent out, and it got screwed up, so we never got that. But we did get an influenza RSV PCR that was negative. And again, his tick stuff, including anaplasma, was negative. I shot the works for hantavirus. I don't know if any of you remember Navajo fever in the Four Corners. It's been reported in every state. It's associated with rodents, and it's young people can get really sick with pulmonary infiltrates. I'm probably old, and not too many people remember that one anymore. Okay, so this was his admission chest x-ray. This is the radiology report. Bilateral, severe, moderate soft tissue airspace densities present in both lung bases. Could be atelectasis or pneumonia. Non-cardiogenic pulmonary edema or inhalation lung injury is also possible. And these are, again, his actual films. This was his CAT scan, and I'll be honest, this is what, when we got consulted, this is what I found unusual and made me start looking. Because if you notice on this CAT scan, there's peripheral sparing of the peripheral part of the lung. And that, to me, was unusual. I don't see that with pneumonia. And so I literally Googled pulmonary infiltrates and vaping, and that's what got me on this track. And so that was the thing that really caught my eye, was this CAT scan, and it is somewhat characteristic in some of these cases, which you'll see. This is 3 days later after his admission. See, things have progressed considerably. He's much worse. We got consulted on the 5th. This is the 6th. And of course, I treated myself and upped his antibiotics to cefepime, azithromycin, and vanc. And we did consider vaping-associated lung injury. He got transferred to the ICU on the 6th and got intubated. He was in real trouble at this point. So he did get a bronchoscopy performed on the 6th. The silver stain for fungi was negative. The FB stain was negative. Culture and gram stain negative. I think his fungal culture grew some Candida thing that didn't matter. And his blastomyces, histoplasma PCR, I believe were negative. I don't remember if I ever actually got the official report back, but I heard through the grapevine they were also negative. So the question I think that's worth answering here is this clinical scenario consisting with vaping-associated lung injury? And I'm hoping to convince you that yes, it is. So again, we all know this has become a real problem in our throughout the United States. We can go ahead. So first of all, I think it's worth defining, and I actually looked all this up because I wasn't familiar with this as an ID doc. So vaping, it consists of inhaling and exhaling an aerosol, often referred to as a vapor, produced by an e-cigarette or a similar device. It's used, the term vaping is used because obviously e-cigarettes don't make smoke, but they intentionally make a complex aerosol. Contrary to popular belief, it's not just water vapor. It contains a plethora of fine particles and chemicals. So many of these particles and chemicals have been linked to cancer as well as respiratory and heart disease. I'm not going to talk about those today, though, because I'm not even qualified to do it. Okay, so to get back to where this all was, the cases first occurred, it was in July of 2019. The epicenter was Wisconsin and Illinois. So on July 10th, the Children's Hospital in Wisconsin notified the Wisconsin Department of Health of 5 previously healthy adolescents who got admitted to their hospital within 30 days, presenting with progressive dyspnea, fatigue, and hypoxemia. All 5 patients had a history of e-cigarette use in the preceding days or weeks before symptom onset. On July 25th, the Wisconsin Department of Health issued an alert to clinicians describing the clinical syndrome, and they requested similar cases of pulmonary disease be reported to the public health authorities. On July 31st, the Wisconsin Department of Health was contacted by a physician in Illinois who astutely realized that he had a similar case, and he was asking for guidelines. So at this point, the 2 departments of health joined forces. They called in the CDC to help, and the CDC dispensed an epidemiologic assistance field team on August 20th. Between the 2 public health departments and the CDC, a case definition was formed. And as of August 27th, there were a total of 53 cases that met this preliminary case definition. And here is an article that was published on September 6th, which was the day this man got intubated. And it is a report of the first 53 cases of vaping-associated lung injury that was published in the New England Journal. And so a lot of what we're going to go over today is exactly this. I thought this would be the place to really start. So, by the way, if anybody has questions along the way, please stop me. It doesn't have to just be me droning on. If you guys want to stop and ask something, please do. So this is the CDC case definition of a confirmed case. It's the use of an e-cigarette or dabbing in 90 days before symptom onset. And dabbing is something similar. I'm not familiar with all the ins and outs. And you have a pulmonary infiltrate on plain radiograph or ground glass opacities on chest CT, and the absence of a pulmonary infection on initial workup. And the minimum criteria for the workup includes RSV and PCR for influenza, other clinically indicated tests like we did, Legionella, pneumococcus, etc. No evidence of an alternative explanation for the presentation. A probable case, which is what our patient fit was use of an e-cigarette at the same time frame, opacities on the chest X-ray or chest CT. Infection was identified in him. Remember, he had a light growth of MRSA, which probably was just colonization, but technically this took him out of the confirmed into the probable. And again, the minimum criteria to rule out these other infections. So again, I'll give you a list of those. So these surveillance case definitions are, again, I'm quoting them exactly, and they're not for purposes of clinical diagnosis, although I think they're very helpful. And again, we talked about what vaping is here. There's a dab pen and vaping. Again, dabbing is superheating the device for inhaling substance such as nicotine. There it is in their case, what they're describing there. Okay, so this is those 53 patients. Their median age was 19. As you can see, the spread 16 to 53. Most of them were male, 83%, 82% Caucasian. 30% had a history of asthma, 34% had a history of some type of mood or anxiety disorder. So 61% reported nicotine use, 80% reported THC use. Notice that not everybody who had this did THC. I think that's important to realize. Okay, and we can move on. And so these were the symptoms respiratory symptoms at onset. Again, 98% had some type of respiratory symptoms, 87% shortness of breath, 55% chest pain, cough 83%, hemoptysis 11%. Gastrointestinal symptoms, I really do want to point this out because that's how he started. He had nausea, vomiting, diarrhea, and malaise. And if you see there, gastrointestinal symptoms are 81% of patients had that. So, and it often will precede the respiratory symptoms. So I do really want to point that out. And he lost weight, by the way. That if you notice there's weight loss in there, he had lost a fair amount of weight, like 10 pounds. Okay. So here's the laboratory abnormality summarized for the first 53 cases. Notice that 87% had a white count over 11,000 at presentation, meaning leukocytosis, obviously. Remember, he had a white count of 15,000, and by day 2, his white count was 35,000. I don't remember if we got a SED rate on him or not, but one thing I also want to point out, he was 50% of patients had abnormal liver function tests. And again, our patient had abnormal LFTs. And the procalcitonin level was not particularly elevated in these cases, mildly up, but not anything staggering. 91% had an abnormal chest X-ray, 100% by CAT scan, and the case definition is bilateral infiltrates. So by definition, everybody has bilateral infiltrates. And that would make sense because it's an inhalational lung injury illness. So I thought this was interesting. This is where the Illinois Department of Health went back and looked at their who got admitted with severe respiratory illnesses that were young patients and compared 2018 with 2019, and they saw a doubling in 2019 of young patients getting admitted with respiratory illnesses. So it doesn't prove that there's an association, but it certainly makes it suspicious that maybe there were cases that nobody knew about. So most patients are really young. The average age is 20 years, male predominance, 80% report a history of THC. That means 20% have done something else, and 94% report vaping within a week of symptom onset. And so severity probably varies from those who probably have unimpressive symptoms to those requiring intubation and ECMO. Our patient barely made it out alive, by the way. When he got bronch, they did not want to do a transbronchial biopsy because they thought if they dropped his lung, he wasn't going to make it. So they didn't even do it. The initial case series, like we're presenting here, have focused on the very ill patients, and that's what the definition has been designed to catch. But there are probably a lot of these kids walking around that get diagnosed with something else, and they probably just get over it. And over time, we'll probably learn that. So it's usually a subacute onset. They can actually be sick for a few weeks. It's averaging, I think, around 10 days, something like that, or 6 days. And again, it doesn't have to start out with respiratory symptoms. A third of patients have been misdiagnosed with something else, which is quite understandable. Okay, again, 98% have respiratory symptoms, 81% GI symptoms. I know I'm stressing that, but I think that was so prominent in this case with him that that's what he was suffering with. 100% have constitutional symptoms. And this is important too, I think. Upper respiratory symptoms are not part of this syndrome. If somebody's coming in with a lot of upper respiratory symptoms, this is probably not their problem. And so this is, I think, interesting. Is this is where we start looking at different patterns of lung injury that have been associated with this, with vaping. So there's what's called an acute eosinophilic pneumonia pattern, an organizing pneumonia pattern, a lipoid pneumonia pattern, and a diffuse alveolar hemorrhage pattern. So there's 4 different patterns that can be seen, and we're going to look at those now. And we can skip that one. Okay. So these are chest X-ray findings. I don't know. I hope this is coming across. I couldn't tell you this. I'm no pulmonologist. I couldn't tell you acute eosinophilic pneumonia from lipoid looking at a chest X-ray, and I'll be honest. But what I do see on these is everybody's got bilateral infiltrates, and that's kind of the definition of this syndrome. And that, you know, in a young patient with bilateral infiltrates vaping, this is what I think we need to be thinking about. The CAT scans I can appreciate a little bit more, and we'll do those next. So core features on CT, bilateral ground glass opacities, features which shouldn't be seen. And are you against vaping illness are dense lobar consolidation, dense nodules, or cavitation or necrosis. Okay, so here's what things look like. I've got 3 of the 4 patterns. I did not give you an alveolar hemorrhage pattern. But the first pattern over there is the acute eosinophilic pneumonia pattern. And if you can see here, there's dense ground glass opacities on both sides, and there's a lot of septal thickening. This is probably easier appreciated by a pulmonologist than me, but I can somewhat appreciate it on the first 2 there, that there's a lot of septal thickening, and that's characteristic of the eosinophilic pneumonia pattern. And if these are the people, when they bronch them, they get eosinophils out of their lung, but they do not have peripheral eosinophilia. Okay. This is what I think our patient had, the organizing pneumonia pattern. If you look there on the left, there's sparing of the lung periphery. And that is what to me, his CAT scan looks like. And in fact, our patient, I think, was a little bit of that and what they call a lipoid, a combination kind of thing, which I'm sure happens. And the organizing pneumonia pattern can be more diffuse, as you can see there on the CAT scans on the other 2 images. But that's a fairly characteristic finding of this problem, is this peripheral lung sparing. This is what they call the lipoid pneumonia pattern, and they call it crazy paving, where you have blotches of areas that are infected with adjacent areas of lung that are not infected at all. And I think he actually had a combination of this and the organizing pneumonia pattern. So what about bronchoscopy in these patients? It's felt that most of these patients don't require a bronchoscopy for diagnosis or treatment. Potential indications are significant immunocompromised patients. They've got something else to suggest that there could be an unusual infection going on, such as fungal pneumonia. By the way, we actually did briefly have him on voriconazole, again, treating me probably more than him. And if the patient's intubated for another reason, like this gentleman was, because he needed to be, because he was too hypoxic, he was in respiratory failure, then they say, sure, do the bronchoscopy. What was I going to tell you too? We can go ahead. And this is an algorithmic approach to how they are talking about diagnosing and treating this syndrome. So this is, again, part of what the CDC also recommends. So, so a case that's suggestive is what we were just talking about: history of vaping, bilateral infiltrates, not immunocompromised, and no exposure to unusual pathogens. As far as a non-invasive workup, the minimum is 2 sets of blood cultures, sputum gram staining culture, urine for Legionella and pneumococcal antigen, all of which he had, PCR for viruses and influenza. We were able to get the influenza and RSV. He had MRSA, but again, I think it was a minor player in him. HIV was negative in him. We did not, I don't remember us having the ESR and CRP, but I know we did the procalcitonage. So they, again, further investigation could be a bronchoscopy for additional testing. And again, if they're intubated for another reason, it makes sense to do that if you're worried about an unusual pathogen like fungal pneumonia. As far as therapy, they still do recommend antibiotics for this. Nobody really knows, again, to sort of back up, nobody still knows what's really causing this. There's all sorts of theories out there, whether it's like the vitamin E theory, or who knows what this really is. So they're still recommending that you treat for like a community-acquired pneumonia, ceftriaxone and azithromycin, and you give steroids. And that's what this gentleman got. He got it, and then you do a long taper of steroids over weeks. And you can discontinue the antibiotics. And it's, in most cases, a lot of these guys got their antibiotics discontinued. Some of them went home on antibiotics too. He did not. We stopped his. And by the way, I don't tell you this, but he did eventually get better, and he got extubated and he went home. So he made it, but he was definitely in a life-threatening situation. Okay. So as far as New York State case reporting goes, they want you to not only call the Department of Health, but also to notify poison control. And this was an email that was sent out by our infection control group here. And I just wanted to throw this up for anybody here in New York State that you're supposed to notify both the health department and poison control about these cases. Okay. And so we can stop there. I want to, before we go on to anything else, let's just see if anybody wants to talk and say any questions.
Okay, if anybody does have any questions, feel free to unmute yourselves. It's *6 if you're on the phone, or you can just click the microphone in the lower left hand of your screen. We did have a question that was put in via the chat by, I believe, Justin, and I'm sorry I lost the question. Can you just repeat it for the group? And that was related to the chest x-rays, I believe. All right, if anyone else has a question, maybe Justin will pop back in a second. All right.
Okay, we can
All's
go
quiet.
on. We can go on. That's fine. Just a few little more things that I think are worth mentioning here, and that is this got published on September 19th in the New England Journal of Medicine. So it's Trends in Adolescent Vaping from 2017 to 2019. It's an editorial letter that it has, so it's not long. It's worth reading, and it's got a table I want to show you here next.
So we did actually end up with a question, if I can interrupt quickly.
Sure.
So this is from Dave Frostick, who's a PA at CVPH. Do we have any idea how these people do post-treatment?
I don't know what the follow-up has been like. From what I understand, most of them seem to have fully recovered, but I haven't heard anything about long-term follow-up of these patients.
And the other question actually that we had from Essex County, looking at x-ray findings, any level of concern associated with the differing findings on x-rays, ground glass opacities versus infiltrates?
So I'm not totally sure I quite understand, but let me try to explain what I think they're asking us to look for on x-rays is basically bilateral infiltrates are key. And so you've got a young patient with bilateral infiltrates that vapes. This is probably something you need to be considering. And I will point out again, I'm an ID doc. I'm not a pulmonologist, so I'm no expert on reading chest x-rays. But the key here is bilateral infiltrates. So if you have a lobar infiltrate in one lobe, that's probably just a regular bacterial pneumonia. But this looks, as you can see, this sort of looks like bilateral stuff. It can look like a pulmonary edema pattern. So that's kind of the key, is that you've got infiltrates bilaterally. I hope that answers it.
Thank you. And that looks like it for questions for now. So we'll keep going.
Okay. So again, this was published September 19th, and it was a letter. It's got a nice table that I want to show you, sort of as some follow-up here about what's been happening in vaping in the United States. Okay, so this is looking at vaping in adolescents from 2017 to 2019. And as you can see, across every year, it keeps going up at each age group. It's frighteningly how fast seems to be catching on. So the 12th, by the time you're in 12th grade, daily vaping 11.7%. That's frightening. And yeah, we can move on. So this is straight out of the article. It says table 1, which we can go back to look, shows a significant increase in 30-day, well, let me go ahead, I'm sorry, nicotine vaping in samples of each of the 3 grades from 2018 to 2019. Vaping prevalence more than doubled in each of the 3 grades from 2017 to 2019. And in 2019, the prevalence of nicotine vaping during the previous 30 days was as follows. 1 in 4 students in the 12th grade, 1 in 5 in the 10th grade, 1 in 11 in the 8th grade. And if you want to go back so they can take that table in a little bit better. I mean, that's scary, I think. 1 in 4 is what we're seeing in the United States right now that have been participating in this as of 2019. That is a scary thing. And I'm pretty scared of it. I have a 12-year-old that's just entered 7th grade, and it makes me nervous. Okay, anybody have a question about that table or anything?
So we did have a note from Wendy, and she's saying what would be interesting to know is whether these individuals were obtaining their vaping materials from certified suppliers. Under the age of 21, these materials would be obtained on the black market. That's a question.
Yeah.
Do we know where your patient?
Yes, and that was, at least I know where our patient got his, and I should have pointed that out. He has been using the same retail store for 6 years that is right here in town across from the butcher block, and he's been going there for 6 years. He doesn't get it from anywhere else. He doesn't use, but that's the only thing he uses. Unlike a lot of these younger kids that are using 12 different products, our guy was a pure case of just using one product for 6 years, and he doesn't get it from anywhere else. So I don't know about these cases of how many of them are black market or how many of them, but this was from a registered licensed place that our patient came from.
That's interesting to know.
And that was a good question. I should have addressed that earlier. Thank you.
Did they ask for the product? Did we send it in?
Yes, I think the Department of Health went after that. And that's what they want you to do, by the way, is to, when you do report, that's part of the reason the health department needs to know, because they're going to go out and try to collect the stuff and figure out what's causing this. So again, this is straight out of the article. Efforts of there's got to be efforts to stop this. Obviously, 1 in 4. This is getting ridiculous. And it's the other thing I'll point out that I've learned since in the last 2 weeks is this vaping, even the nicotine stuff. I didn't know this, but I've learned it now, which is they spike it. It's a lot higher than you get in a cigarette, and so they really are hooking. Forget for a moment the acute illness here. They are hooking kids on nicotine like in nobody's business here. This is really high nicotine levels, and they get hooked because they can control how much nicotine goes in these things, and they put a lot in there. So this is my own personal thoughts about this so far. I think we should ban this stuff outright. Probably not going to happen, but I think that's what we ought to be doing. Again, I don't think there's any evidence that flavored e-cigarettes are any worse, but they're certainly what's attracting a lot of young adolescents to start doing this. And I think that makes sense for that ban. If we can't do anything else, maybe we could at least do that. Again, should we be banning THC-containing products? I think so. 80% of cases were with THC vaping. And I think now we're to the point, if it's 1 in 4 out there, we've got to be talking to our children and explain to them that this is a bad thing to do, or if they're doing it, to try to get them to stop. And again, I have a 12-year-old myself. It certainly worries me. And with that, I'm hoping that maybe you guys can would have some other thoughts or comments on what you think ought to be done. And I'll leave it at that.
New York actually banned all flavor.
Did they?
They
Finally.
did.
Yeah.
Yep.
Good.
I think it's either Connecticut or New Hampshire that banned all vaping products.
They actually are working on joint legislation,
Yeah.
Connecticut and New Hampshire. Yes, so I did just hear about the state of New York providing a ban. And so if anyone does want more information on New York State's take on this so far, they have a lot of great information on the DOH website right now. And if you'd like, you can email me and I'll send you the specific link. And Wendy just added in, this is unfortunate that this has occurred with vaping. It has and was an effective means of getting people to quit smoking.
I agree, but I will point out, can we go back to my very first slide? I just want to point one thing out. This is what I still think is true, and maybe a pulmonologist could say it better than me. The very, very beginning slide.
We can.
Thank
If you
you.
give me 1 second.
Sure. Okay, I have a little thing down there that I think I want to just point out. When are we going to learn that lungs have evolved to inhale air and nothing else? That's my take on all of this. Aside from asthma medicines, that's what lungs were designed to do, not this stuff. Okay.
All right, I'm going to open it up. We still have a good amount of time left. Welcome group discussion. You can unmute yourselves, turn your video on. Any comments? Yes, Wendy says touche. We'd love to hear from you. Just general thoughts. This is good discussion. This is a session that we're recording and would be happy to share with other folks who weren't able to join us today. So I'd love to just hear from the community that we have today.
Yeah, I'd like to hear some in your own counties of what's going on, and you know, have you heard of anything that sounded suspiciously like this is going on? And how many folks are in? Do you know what the kids in your own counties are doing? Because, you know, again, this is not what I normally do, but I'd be curious to see what you guys are hearing out there.
Don't be shy.
Hey there, Dr. Collins.
Yes.
Hey there. Hey, guys. Excellent presentation. Really, really awesome. Thank you.
Thank you.
I do know, and this isn't any kind of private knowledge, but several schools are looking to install detectors for the vape smoke. I don't know if anyone else is on here has heard any more since the original article went out about schools that wanted to do that. That'd be cool to get some more insight. But schools, I know we're looking into doing it to try and combat this in schools, which is definitely a problem. People have them in these small USB pens. They're only like half an inch long, and they can hide them so easily.
Good point. Really good point. The other thing I know that is happening too is that they're making these pens look like magic markers or something else, so they can take them to school and they don't even recognize what they really are.
Mm-hmm.
That was intentional too, so that they can say what they want about not trying to market to adolescents. I'm sorry, I'm jaded, but that's just baloney.
And actually, we did have someone just follow up with us. It may be Ann Haywood. I'm not sure. I don't have the full name, so correct me if I've got this wrong. But she's just letting us know that Saranac is actually a test site for those vape sensors that you just mentioned. I did read the same article and thought that it was Plattsburgh, but looks like it's Saranac. And Ann, if that is you, could you just throw something in the chat box so that I can give you credit for attending?
I'll just say, well, so if any of you have any questions, that's great. As an ID doc, I'm not going to become an expert in this by any means, but I think as ID docs, myself and my other colleagues, we have to know about this because we're going to be consulting on people that are going to have this illness, and that's how I fell into it. And I'm sure you guys are going to see this stuff in your clinics. It's just not going to be maybe, you know, you could have somebody walk in just as bad off as this, but you'll have probably cases that are not near as bad as this. But at least I'm hoping you get in tune with what to look for now.
I'll just tell the story of my son was offered a cigarette on a school bus when we first went to kindergarten, you know, at age 5.
Oh my God.
But what I'm thinking is that was you know, 30 years, almost 30 years ago. But now,
God knows what they're offering.
now they would be just offering them a hit on
Yeah.
nicotine. You don't even have to light. You don't have. It couldn't be lit in the school bus, obviously. But now,
Yeah, you're right.
now you can just take the drug right out of the device in the school bus.
Yeah, it's scary. It really
Scary.
is.
I'm wondering, just because of the connection that I have with New York and the fact that they did just put that flavor ban on, Personally, my daughter is a freshman in high school. She just went in, and for the past several years, she's been a member of our local reality check group. And she actually went to Washington, D.C. and lobbied, and one of their biggest targets was the fact that they had so many flavors that truly it would be hard to say weren't targeted at children. There's cotton candy and Captain Crunch, and it sounds delicious, honestly, but I'm wondering what everybody's thoughts are on just banning the flavors. Do we think that that's going to have an appropriate impact if the only things that are available are tobacco or menthol flavors? What are everyone's thoughts on that? And just also from Wendy, she's mentioning, I appreciate this discussion. We had a 15-year-old male present to the clinic with a fever of 103 and illness. It was at that time that his parents and family were made aware of his vaping and the potential effects of vaping. Yeah, obviously this 15-year-old's parents didn't realize that their child was vaping.
It's interesting to me that this seems only affecting the young, the illness is only really affecting young people. You would think the older population would be more susceptible to it, but obviously there must be something about the pathology there.
So I don't know. There are some that were even in their 50s in that original case series, but they're not as common. I just think maybe, John, I don't know myself, that it's really caught on in the young group. And
Maybe it's because of the number.
yeah, exactly. It's really in the young that vaping seems to have caught on such a, like fire, for want of a better word. And the older ones probably still smoke.
Yeah.
Or they do pot or whatever they do. Yeah.
I had a question.
Sure.
It's Leanne. Have you looked at any of like the biopsy or autopsy specimens at like histopathology of this and what it looks like?
Yes, there actually, I skipped a slide about that. And again, those patterns I was talking about are also true on the histology. Like for instance, the eosinophilic pneumonia, they get eosinophils on the path. With the organizing pneumonia, there's particular inflammatory reaction that occurs that is typical of an organizing pneumonia. It's got a lot of lymphocytes in it, plasma cells, monocytes, and I don't know about how much fibrosis, but I believe there's some of that as well on the organizing pneumonia pattern. And then I didn't talk about it, but they can present with pulmonary hemorrhage as well. But there are some characteristic things on the histology. I just didn't show that off, but it's interesting to me that even though they have an eosinophilic pneumonia, they don't have eosinophils in their blood, and I think that's worth keeping in mind. So you can't screen for it like that.
Yeah, and as a non-healthcare provider, I'm finding it really interesting that fever is associated with this almost always.
Yes, almost
Can you comment
always.
on that? I mean, I know you're not a pulmonary specialist, but is that kind of unique for what appears to be a toxic exposure?
What my thought about that is, and this is just me, I don't know, is that, lots of things can trigger endogenous pyrogens in our body. And the lungs are probably pretty good at releasing endogenous pyrogens, like interleukin, tumor necrosis factor alpha. They're probably getting released. This is conjecture. But that's how ID docs are going to get involved, because they're all going to have these fevers and they're going to have these pulmonary infiltrates. But I think it's, do we even know for sure that there's not an infectious component? No, that's why they're still saying give antibiotics. My own gut tells me that this is a toxin-mediated inhalational injury. But I think whenever you injure tissue, like lung tissue, you're going to get a lot of endogenous pyrogens released, and you're going to get fever. I mean, they have chills and everything, these kids.
It's weird because I actually have a PhD in toxicology. I haven't worked in that field in a long time, but to me, it's really unusual that fever is there. I don't know that that's associated with any forms of lung injury. So I'm going to have to look at that and see.
Right. I think, like, for instance, just the amount of tissue damage that's happening to the lungs, I think, is what's driving it. But again, I'm not sure.
Right. Yeah. Mm-hmm.
One thing that I definitely appreciate is the fact that your case presentation patient did not have any black market access to products, because, of course, being involved on social media, and, I technically am a member of the millennial generation, and so I have a lot of contacts that do this and are up in arms that there's any kind of ban happening at all because they're blaming this all on people purchasing black market products. So I think one of the best things that could be done is just make sure that people are aware that even buying your products from a licensed distributor can still cause these effects. I don't think that that's known enough.
I agree, and I think that's why this particular case, as you said, is so important. He did nothing else. So, and I mean, this guy has just been going about this for 6 years, and though he had not changed anything, and boom, this happened to him. So something's going on out there, and it's not just black market stuff. Very good point.
Quick question.
Sure.
So, a big part of the MMWR kind of report, like for the week and also on the state call, they had discussed it, but not too extensively, was kind of the role of like lipoid pneumonia, because the lipids that are found in marijuana oil and the concentrates and the other e-cigarettes, and that people who, a lot of those cases had lipid-laden kind of macrophages. Is that something that they're still kind of looking into? Or is that something that you had seen maybe in this case or had heard of in other cases that's concerning?
I have heard that. I didn't mention that in here, but I did mention, I think in this case, I think he had a bit of lipoid pattern on his CAT scan. But you're right, they see lipid-laden macrophages. It makes sense with the oils and THC. It would make some sense. I didn't mention that in this. Yeah.
Certainly, especially, I mean, would a macrophage kind of could that lead over into the fever, given that you're having a macrophage in kind of a foreign body almost, right?
Oh yeah, exactly. And those macrophages are going to release all sorts of stuff. You're absolutely right. Sure.
Kind of just terrifying, really scary.
Yeah.
Yeah.
Exactly. I never thought I'd see the day when I thought cigarettes were better than vaping, but it's here. Yeah.
All right, I'm going to open it up for any last questions or comments. Just a note from Mona in response to the question I posed earlier. She doesn't think that flavors make a difference. It's a little bit of a peer pressure, trying to be cool with the latest trend as potentially what's driving this. So if anyone else has any comments or wants to weigh in, I can tell you that New York State will be viewing this presentation. This is a good way to get a captive audience if you have anything you'd like to input.
Right, let New York State know now. This is your chance.
Sorry, New York State, I'm giving everyone a soapbox here.
Yeah, there we go.
No takers.
By the way, I don't know, John.
I'll offer a suggestion. Let me ask
Okay.
you. I know that Justin is there. A few people are there from the Essex County Department of Health. And I'm wondering if with this kind of emerging public health crisis, it's an environmental thing, right? Do you feel you have the resources you need to get out there and inform people about this problem and intervene? Because I'm big on getting more funding for public health initiatives here in the North Country. And so I'm on my soapbox.
Good.
What do you think?
Wow, awesome question, definitely, Leanne. We do work with the state at the higher level, mostly for this. This also is kind of a chronic disease. That's kind of how we separate it out. So funding would be for chronic disease, cessation in this case. Liz, are you still on the call? Are you here? No, but anyway, so we do have a kind of end of Bureau of Clinical Disease Control. I don't think that they kind of have, it's so new and fresh. I don't think they've quite figured out like the funding stream kind of thing for this, to be honest. Based on the calls the other day, BCDC, which basically is the area that we respond to for clinical disease, still views it and is got a task force kind of set up for it. Started a line list on those cases and is investigating it as kind of a disease. But, on the prevention side, that needs to then be technically from chronic. It's not like a TB disease where it's
right
from that straightforward only in CD area. And so that's the challenge. It's creating these problems, but it's not something that's a traditional, age-old thing on our, clinical disease reporting requirements list.
Right.
So you see at that surveillance level, that's kind of where that where it gets kind of complex, I think, for the state level to start doing things about it. And then, you know, money comes to us from that. It kind of boils down, kind of trickle down.
Right.
If that makes sense. But at this level, we're going to get, you know, with the state, usually the state will give out templates for things like this, try and get notices out to people. Definitely on our social media sites that we have access to and can control, we definitely will put on something for, you know, cessation of vaping and that it's dangerous. And anytime the state puts out an official statement like they have, that definitely will be re-forwarded. Like, look, this isn't just something that our county thinks, this is statewide. And that way we give somebody a message is with a little bit tense of authority.
Right.
That's kind of how that kind of will go.
Yep.
I'm not sure if Franklin or Clinton or somebody else from another county is on.
I know that we have Clinton County on the line. Any statement or advice from you?
Is that Peggy?
And it's a *6 if you need to unmute yourself on the telephone. Otherwise, it's the mute button in the lower left-hand corner.
While they're figure that out, just a note about like health departments is small ones don't have environmental. So this also could be seen, you know, kind of like traditional smoking was seen as creating, instituting environmental rules. All larger ones would be able to, smaller ones like us don't. We use state level, you know, Department of Health for all environmental concerns. So that's another thing, is that they're really on this, definitely. This is definitely something that is being seen too much to ignore.
Yeah, good point. Are they going to be able to, if they want to download this case and send it to somebody else, can they do it?
Sure. It's a little outside our norm. So again, this is a part of our normal Project Echo series and our normal disease process. Focus right now is tick-borne illness, but luckily we were able to get approval from the state of New York to deviate off of our curriculum for this one session, just because of the emergent health crisis. And thank you to Dr. Collins for bringing this case forward and preparing it so quickly for us. So this is something that we will have recorded. The entire session is recorded this time, which again is different from our normal process. There is absolutely no PHI in the case presentation, and we knew that ahead of time, which is why we were able to record the whole session. So if anyone would like to have access to that recording after this, we'll have it posted on our Project Echo website. You can reach out to me via email and I will send you the link to that website, and that'll be the easiest way for you to access this. And I welcome you to share it with colleagues, share it with your kids if you need to. It may be a little over their heads or boring, but you know, a little fear and education never hurt a teenager. I don't think I have two of them myself. So on that note, I don't have any other comments in the chat box.
So one last thing I would like to say is thanks again for everybody for attending this. And, you know, one audience that I think needs to really be focused on are pediatricians. I hope that they're getting this out and that they're getting good information, because they're just as likely to see this as, I mean, probably more likely than I'm going to see it. I'm an adult ID doc and I'm only going to see, but pediatricians really need to, I hope, get a lot of information out to pediatricians. I just wanted to mention that. I think it's important.
And so I will at that release you, but if I can grab whoever is coming in from Health 90 and Health 69, can you either hop on the mic and let me know your name or type your name into the chat box for me? We're just monitoring attendance for our program and for New York State, please. And everyone else, thank you for joining. I appreciate it. Have a good afternoon.
Thanks.
Thank you guys, as always.
Thanks, Justin. And that was Health 90 and Health 69. If you can just pop on the mic.
Thank you. I didn't, it was thrust upon me.
Yeah. You figured it
Okay.
out.
It was fun.
Perfect. Thank you.
Yeah, thank God for Google. I said, that's all I did, pulmonary infiltrated space, and boom, there it was.